Hi friends, Pradeep Pendyala, Professor of Anesthesiology. Today in the morning I got up and received a wonderful message from a dear friend, Dr. Tushar Choksi. Dr. Tushar has sent me a lovely infographics of NORA. Don't be confused, NORA is nothing but non-operating room anesthesia. I read that, inspired by that, and also we had a class this afternoon on the same topic. So let me share few of my experience and my information about NORA, that is non-operating room anesthesia. It presents a new aspect of patient care for anesthesiologists all over the world. The interesting part is interventional radiology. Suites, people call it suites, S-U-I-T-E. It's not suits, it is suites that require CT scanner and fluoroscopy. MRI suite requires appropriately trained personnel who understand the dangers of electromagnetic radiation. Recently, we lost an operation room technician in Hyderabad who entered MRI room with a normal oxygen cylinder. Normal oxygen cylinder has the metal that is molybdenum steel, and that is attracted to the magnetic radiation and the equipment there, and he died instantaneously. This happened 2 years back in Hyderabad. Which is compliant, MRI compliant oxygen cylinders are usually made of aluminum. Similarly, MRI compliant anesthesiologists should know the operation, how we manage in that area in MRI. Operationally, these environmental constraints restrict the ability to provide patient care, and NORA is definitely very, very challenging. I must say, the idea of talking about this is to impart some information which may not be known to many people. Incidentally, it's growing like mad. More than 50% of operations all over the world is nothing but NORA, non-operating room anesthesia. So we must know how this takes place, and we must know what are the intraoperative considerations and what are the things we must know. Despite the development of monitoring guidelines, the uniform implementation of monitoring standards in NORA settings are slightly different from the normal operation room setting. So you have to be conversant about that, and there could be problem of hypoxia and monitoring in the constrained environment. The people working in NORA may not be well conversant with the anesthetic practice, and the equipment may be old, may not be well maintained. So suddenly, if an anesthesiologist is asked to give anesthesia at non-operating room anesthesia, he may face many challenges. Firstly, the anesthetic equipment may not be well maintained, and it's whereas the normal operation room anesthetic equipment is normally very well maintained, and there is well-trained staff, whereas the staff at NORA may not be well trained and the equipment may not be well maintained. So that would be very challenging. Simple pulse oximetry also sometimes fails in such situation. So people should be very cautious about giving anesthesia, and I would always advise to give propofol or Dexmed or anything, a combination of Tiva or anything, in titrating doses. Giving suddenly excessive dose can cause problems. And we must know how the pain management is done in such situations, And regional anesthesia definitely offer other form of analgesia here, and it can be done whenever it is required. NORA allows many more invasive techniques like endoscopy, and I'm sure endoscopy definitely needs NORA, and more so in EGD, esophagogastroduodenoscopy, and ERCP also, I'm sure you know, endoscopic retrograde cholangiography. Such things normally anesthesiologists are asked to give anesthesia. But here, the endoscopic procedure requires patients to be in prone or semi-prone position, which can compromise respiratory mechanics and limit access to the patient's airway. The use of sedatives during endoscopy can depends on the anesthesiologist's preference and the requirement as per the thing. A topical local anesthetic such as lidocaine would definitely be suitable to be applied in pharynx to aid in the insertion of endoscope. And I would suggest common choice should be benzodiazepine or midazolam, either alone or in combination with fentanyl. And sedation can diminish airway reflexes significantly. That can increase the chances of aspiration. And those who are not appropriately given NPO, they can cause further chances of aspiration. And it's normally now even is being prevalent in interventional pulmonology. Also is very much using NORA. So people should know how to be conversant about it. There are several preoperative considerations for interventional pulmonology to be considered. Patient position during interventional pulmonology procedure typically requires hyperextension of the neck. As a result, patients should be assessed for risk factors because it can be difficult to intubate and there could be chances of hypoxemia or hypercarbia. So we should know as per the each procedure, successive procedures in bronchoscopy require adequate suppression of airway reflexes. Therefore, topical anesthesia with local anesthetics is important in ensuring patient comfort. You can be asked to give NORA in interventional cardiology also. That is very common, and like in situations like percutaneous coronary intervention. TAVR is very much coming up, percutaneous transcatheter aortic valve replacement, and TMVR also, transcatheter mitral valve repair. NORA is very much required. Monitoring interventional cardiology patients should be emphasized detection of hemodynamic changes when giving anesthesia. And you have to be very, very careful, extra cautious. As I said, give drugs very carefully, very judiciously. Keep everything ready, like suction apparatus, defibrillator, such thing, and monitoring is paramount. And transthoracic or transesophageal echocardiography can be used as an adjunct for diagnostic imaging and monitoring of cardiac function. So, when it comes to interventional radiology, that's one more very challenging for NORA. Today, the extent of diseases and conditions that can be treated with interventional radiology has grown considerably. Anesthesia, anxiolytics, opioids, and epidural anesthesia might be required by interventional radiologists. So, NORA is very much applicable as anesthesia and healthcare provider should always know what are the limitations, what are the expectations in such situation. And I have already mentioned about MRI and the problems, and a word about pediatrics. The pediatrics population offer unique challenge to anesthesia providers. Anesthesiologists must pay attention to age and comorbidities and psychological development. Children have different anesthesia requirement altogether. And reasoning with children, understanding their emotions is very important. There are many uses of local and regional anesthesia in NORA settings, including pediatric cardiac catheterization, lumbar punctures, and bone marrow aspiration. Anesthesia for cardiac catheterization is required for vascular access and post-procedure analgesia. Caudal anesthesia is an effective regional technique for subumbilical analgesia in pediatric cases. Lumbar punctures are commonly performed in pediatric patients. Examination of CSF provides diagnostic information for possible infection. In children, topical EMLA, the combination of prilocaine, locally applied cream, and injected 1% lidocaine without epinephrine are very often used. Local lidocaine has a disadvantage because it provides immediate pain relief but may obscure bony landmarks. That's creating more difficult the procedure. Topical EMLA can prevent this but may require a very long time to act for its analgesic effects. So these are the problems, and some more things which I wanted to add is the combination of remote nature of NORA and the diversity of patients in the pediatric population provides very, very challenging. Unless the anesthetist is very conversant about the procedure, it can cause even harmful morbidity or even death. Such things are possible in NORA. And IVF is very much increasing these days, in vitro fertilization, and even there the requirement of NORA may come into. In that, IVF encompasses a series of procedures that involve ultrasound guided oocyte retrieval fertilization. And the thing in the oocyte retrieval, women will typically experience pain, and that needs analgesia. Thus, analgesia is given, but the procedure can cause harm to the child. Not very sure. This combination of anesthetic drugs and local anesthesia also, how it affects the oocyte is not very clearly known. Like retrieval oocyte can be performed under paracervical, epidural, spinal, or intravenous sedation, or even general anesthesia. Each technique described have advantages and disadvantages. Paracervical block can be performed with lidocaine and a little bit of sedation, but egg retrieval and this thing can be painful. For that, spinal anesthesia also can be given. So a combination of fentanyl along with lidocaine and spinal anesthesia can make patients very comfortable. And intravenous sedation and general anesthesia offer other techniques to ensure successful procedure for patient. I hope I have conveyed few of the points which you might not be knowing about NORA. And thanks for the patient listening. Have a wonderful day. Until next time, take care. Bye-bye.